conversation together with PICAM. We are joined today by a powerful panel of five experts who will talk us through the kinds of barriers that confront undocumented migrant women in the EU when they need to access quality maternal health care during pregnancy, and how the COVID-19 pandemic has exacerbated these barriers. I'm also pleased that we will be able to hear about examples of good practices that exist in certain EU countries and that we believe can provide a model for other member states to follow. Before I introduce our panelists, just a couple of administrative information about the format of the discussion. We are hoping to have a very interactive conversation, and I'll begin by posing a number of questions to the panelists. We'll also take questions from the audience throughout, so please write your questions and comments in the Q&A box so that I can ask our panelists to address them as we go along. You can find the Q&A box in the menu below next to the chat. We may not have time to answer all your questions, but we'll definitely do our best to address them. And we're also recording these roundtables, so we'll definitely be able to do a report that we can share with the participants. Now, I'm delighted to introduce our panelists, and due to time, I will simply just introduce them very briefly. I won't share their rich bio, which we'll actually put in the chat, which you can click on and get to know more about our speakers today. So I'll start off by introducing Michelle Livoy, the director of PICAM, and our co-convener of today's roundtable. PICAM is a network of 168 organizations across 34 countries, primarily in Europe, working to ensure social justice and human rights for undocumented migrants. We have had the pleasure to collaborate with PICAM for a couple of years as a center. Next, I'm very delighted to introduce Virginia Wangari Greiner, who is the founder and CEO of Maisha, African Women in Germany. Maisha is an organization of African women living in Germany that helps the African women to navigate the public administration system in Germany and facilitate their integration into German society. Welcome, Virginia. It's also my singular pleasure to introduce Josef Bartovich, who is a technical officer at the World Health Organization's Regional Office for Europe in the Migration and Health Program. Among other things, WHO Europe supports European governments to create migrant-friendly health systems. Welcome, Josef. I'm also going to introduce Claudia Lam, who is the Deputy Director in the Office of the Commissioner for Human Rights of the Council of Europe. The Commissioner for Human Rights mandate is to ensure that the Council of Europe member states fulfill their human rights obligations. And finally, I'll introduce my colleague, Katrine Thomasen, the Senior Legal Advisor for Europe at the Center, who among other things leads our work on maternal health care for undocumented migrant women in Europe. Welcome, Katrine. I would like to also give the apologies of Alice Bach-Kunker, who was one of our panelists, but unfortunately could not join us this morning. She sent her, her apologies. So we'll go straight into the questions. Each of the panelists has a couple of minutes to answer the questions. So please go ahead and as they start talking to us, put your comments and questions in the chat, and we'll break off after the first round of questions to take those questions and comments. I'm going to start off with Virginia. So Virginia, you're working closely with undocumented migrant women in Germany to help them gain access to maternal health care. Can you tell us what the situation is for undocumented migrant women and the challenges they face in accessing maternal health care? And also, if you can speak to us a little about how COVID-19 has impacted the situation.
Thank you, Muthoni. And thank you again for the invitation. In fact, Maisha organization means life and was founded by African women living in Germany because of our own situations. And 2000, we found out that because of the harmful traditions women come from some of the African countries where FGM is practiced, we had one lady who in fact could not access help because she had undergone FGM, and it was the one which we call the infibulation, and she was sewn. So this lady was in the cellar and was everybody was expecting the baby is coming, but the baby wasn't coming. In fact, she was almost dying. And with that, we approached the city of Frankfurt and we said, we have a problem because there are a community that needs more help, and we need your assistance. And in fact, that's how the humanitarian Stunde, working with the health city of Frankfurt, the municipality, we founded the humanitarian health counseling center. This year is our 20th year, and we are in fact happy that the city embraced it. Not every city is able to embrace this kind of humanitarian help. The situation of undocumented migrant women, we find it very hard in Germany, especially now during the COVID-19. It has been very difficult before, and now it's even more difficult. Discrimination is one issue. Access to health has been limited. So if there were 2 days a week, it's just 1 day, and it's completely congested, it's full, and you cannot access it. And you have to make, in fact, appointment before you go there. And you have to give your name, and then if you are to deliver your baby, you need to register before. And that gives the administration time, in fact, to be able to report you, because if you have no insurance and you have no money to pay, they will report you definitely. There is no way they are going to you are going to deliver that baby without. And we have to in fact to report 2 weeks before birth. And these 2 weeks before birth for many women has been a challenge. The other issue is that women come very late to checkups. And they come very late because they try to navigate the system. They try to hide. And sometimes when they come, they have multiple problems. Sometimes the pregnancy the baby has not been growing well. She has high blood pressure. She may have diabetes in the pregnancy, and she needs extra, in fact, specialist doctors to look after her. And what we have at the moment in the whole country is just basic. So she cannot pay for special doctors. That means she only can go to the churches and pray for good luck. And I think that should not have happened, and should not happen, especially during this time. The COVID-19 means also there was no access to basic rights. All the food banks were closed, and the charitable institutions.
Thank you very much, Virginia, for illustrating some of the real life challenges that women and undocumented migrant women face, and how you're trying to support them. Joseph, let me turn to you. Virginia shared some of the experiences from Germany. Can you paint a picture for us across the European region? What are WHO's greatest concerns regarding the barriers to maternal health care that are faced by undocumented migrant women in Europe? And how have you seen the COVID-19 pandemic exacerbate those barriers? Thank you, Joseph.
Thank you very much, and good morning, everyone. I think I really concur with Virginia and what she has been saying in terms of some of the access issues. We have recently produced a report, the European Migrant Health Status Report. So we're looking at maternal and newborn health in a broader context of refugee and migrant health. But in this report, we have a chapter on specifically looking at maternal and newborn health of refugees and migrants. And I think what we can say in general for the whole of the European region, which is 53 member states, is that refugees and migrants experience worse pregnancy-related outcomes than host populations. Being a migrant is indeed considered a risk factor, according to all the data that we have gathered. It's a risk factor for poor maternal and newborn health outcomes. And while the amplitude and the direction of the difference in outcomes varies between host countries, between the different migrant groups and the origins, countries of origin, as well as the status and the outcome examined itself, there is across the spectrum a marked trend for worse pregnancy-related outcomes among migrants and refugees. Now, these include maternal death, severe maternal morbidity, mental ill health such as postpartum depression, perinatal, neonatal mortality, morbidity such as stillbirth, preterm birth, and congenital abnormalities as well. Now, we have, as I said, quite a broad overview of examples from different countries and pieces of research, which really show us that this is the reality. A study from Russia, for example, found that almost 50% of pregnancies in refugee and migrant women ended in abortion and 10% in either miscarriage or stillbirth, while African refugees and migrant mothers in Sweden were found, I believe, 18 times more at risk of neonatal death. Studies from Italy and Portugal that we are listing found increased preterm delivery rates among migrant women. And in France, we know that maternal mortality is 2.5 times higher in refugees and migrants than those women born in France. And this rate increases even higher. It's 3.5 times higher, specifically for women from sub-Saharan Africa, for women migrants from sub-Saharan Africa. So really, this is a huge concern for us. And not only because of the outcomes, but what we also have some evidence in this report for is the quality of care. And that's another issue. So pregnant, migrant, and refugee women also tend to report that they have experienced suboptimal quality of care. Now, a bit of a glimmer of hope. We also have in this report a number of factors which we list that are protecting refugee and migrant women from adverse obstetric and perinatal health outcomes. And I mean, we know these anyway, but we know that socioeconomic status, educational status, characteristics, and some of the conditions in host countries can really make a difference and improve the outcomes, such as integration policy and so on. So I think this is it in a nutshell. So we are concerned about maternal and newborn health as well, because we link this with the health of children as well, and there are some issues that we are listing in the report. And as I said, I really concur with Virginia. This is a troubling situation, and COVID-19 has, of course, had a knock-on effect and made some of these vulnerabilities even more pronounced. A lot of refugees and migrants are relying on services that have been impacted by the COVID. The routine services, healthcare services have been impacted, but also services of NGOs and charitable organizations and so on that also have been discontinued or had breaks. And this is the lifeline for a lot of refugees and migrants in terms of healthcare. So it has been an issue, and we're looking at ways of improving the situation, of course, and working with our member states to raise awareness of these issues.
Thank you very much, Joseph, for that very elaborate answer and for sharing with us the data on the report that you've just recently launched. I'll turn now to Katrine, because the center also just recently published a report, entitled Perilous Pregnancy, that provides a legal analysis of the ways in which many EU member states' laws still discriminate against undocumented migrant women by denying them equal access to affordable care throughout pregnancy. Katrine, could you tell us what our research has revealed and what some of those major concerns are? And we'll likely put the report in the chat as well for participants to download it and read it at their own time as well. So Katrine, please.
Thank you, Enid, and good morning, everybody. So in our recent report, we looked at the laws and policies across the 27 EU member states in terms of access to affordable maternal health care throughout pregnancy for undocumented migrant women. And we found that in 11 member states, the legal framework requires undocumented migrant women to pay out of pocket to cover the cost of almost all maternal health care. And in these countries, this care is free or highly subsidized or covered by insurance schemes for all other pregnant women. So in these 11 countries, undocumented migrant women who are pregnant have to pay for all antenatal care, examinations, and appointments. They also have to cover themselves the very high cost of delivery care. And if they need emergency obstetric care, again, they have to pay out of pocket for that. In addition to that, there are 5 EU member states where, while the law allows undocumented migrant women access to free care during childbirth or in obstetric emergencies, they have to pay themselves out of pocket for antenatal care. And we found that these cost barriers give rise to a number of serious concerns, both from a human rights perspective and from a public health perspective, as we've heard about from Joseph. First of all, lack of cost coverage for antenatal care has a huge impact on the ability of undocumented migrant women to obtain early, regular, and appropriate antenatal care as recommended by the WHO. In the 16 member states where the undocumented migrant women have to pay out of pocket for antenatal care, it will generally mean that they access very little care. And as Virginia also mentioned, that they often only access care very late in pregnancy. And insufficient or delayed access to antenatal care is very problematic. It exposes pregnant women to higher risks of complications during pregnancy and childbirth, to premature birth, miscarriage, and risk of maternal mortality, as Joseph has also explained. And as we've also heard, we also found that it has impacts on the quality of care that undocumented migrant women receive during pregnancy and childbirth, because often without adequate antenatal care, health professionals assisting at birth will not have the information at hand that they may need, including, for example, to prevent mother-to-child transmission of HIV. Then there are the 11 countries where there's also no cost coverage for care during childbirth and in obstetric emergencies. And although women undocumented migrant women in these countries will not be turned away from care when they are in labor, having to pay the full cost themselves can be debilitating. Often childbirth care amounts to thousands of euros. And we also found that these barriers negatively impact the quality of care that undocumented migrant women receive during and after childbirth. Because of cost concerns, they may not always receive the most appropriate care. And also, they often leave health facilities very soon after giving birth to avoid additional costs. We also found that because of these cost barriers, there may be some instances where undocumented migrant women in EU member states do not obtain skilled care during childbirth, and that they end up giving birth without such assistance. This is highly concerning, as skilled attendance at birth plays a critical role in reducing risks of maternal mortality and morbidity. And really all women in the EU should be able to access this essential care. Finally, we also found in our analysis that even in some of those member states where laws do provide for undocumented migrant women's access to free or subsidized maternal health care, there are still administrative and practical barriers that impede their access in practice. In some of the member states, there's a lack of legal clarity about entitlements to care. Often undocumented migrant women will not be aware of any legal entitlements to care. And they may also have great difficulties fulfilling the many burdensome administrative procedures and requirements that are a prerequisite for accessing free or subsidized care in many countries. The lack of firewalls between health care and immigration services in a range of countries is also a very serious concern that I know Michelle will talk about in some detail. And I'll leave it at that for now. Thank you.
Thank you, Katrine. And you've just, you've really moved us to the next question, where I'd like to turn to Michelle to talk to us. You know, I know that PICAM has done a lot of work to ensure effective firewall protections are in place between immigration authorities and social and health services. Can you tell us about what firewall protections are and why they are so critical in the healthcare context, and how the absence of the firewalls can be so devastating to undocumented migrant women's access to healthcare. Thank you, Michelle.
Thank you, Enid, and thanks to the Center for Reproductive Rights for being able to co-organize this together, but also for your research. It's really important to hear these conclusions that Katrine has just briefly touched upon, because it's part of the evidence base that I think we all as different actors are contributing to. And I think it was also very interesting to hear the WHO report conclusions. And one that I just find also really interesting that Joseph said is being a migrant woman is considered a risk factor for poor maternal health outcomes, just being a migrant. So I think that in order to go into the firewall, I just wanted to also lend myself to what we've heard on the panel so far already, and to commend you for the work. So basically what we consider, and this is where Katrine left off, is that there are worries about the absence of the firewall. What do we understand by the firewall, basically? So this is basically the separation between healthcare providers or educational facilities or social services and immigration enforcement. So it's basically it's decoupling these entities. So it's ensuring that a person who wishes to avail of their entitlements to healthcare can safely go to the hospital, to the doctor's office, and that their personal data will not be transmitted by the doctor's office or by the hospital to the immigration authorities. Within PICUM, we've been working on this concept, I would probably say, since we've existed, and this year is going to be a 20-year anniversary. So basically 2 decades, because we see that in a sense, it's really crucial to have the legal entitlement. But if you have the legal entitlement to healthcare and you still are afraid of going there to avail of it, in a sense, it almost makes it, it's not that it's inexistent, but it really nullifies it in a sense. So we've been working on it for a long time, and it's been, I would say, within the past decade that we've seen the firewall been taken up on the regional and the UN level. And first of all, we had actually the Fundamental Rights Agency in 2013 as a follow-up to their 2011 study looking at the situation of undocumented migrants across the EU. In 2013, they looked at, okay, this is the situation concerning human rights. How do we also enforce these in practice? And so they developed what they call apprehension of migrants in an irregular situation, fundamental rights considerations. It's a 3-page document, which is in a sense one of the earliest, I would say, regional bodies to kind of weigh in on the firewall. And then the former Special Rapporteur on the Human Rights of Migrants, François Crépeau, he did, as an academic, a detailed paper in 2016 in the European Journal of Migration and Law on the firewall. And this kind of then, a lot of this paved the way for, I would say, what is the most robust recommendation that we have globally on the firewall, which is the Council of Europe, European Commission Against Racism and Intolerance, ECRI's General Policy Recommendation number 16. And also, I mean, just to also say in terms of the weight of it, it is about 60 pages long. It covers basically all aspects of the firewall, including on healthcare. We also have the UN International Committee on Economic, Social, and Cultural Rights in a 2017 statement that repeatedly called for the creation of firewalls to safeguard the rights of undocumented people who live in a context of criminalization. So we've heard a little bit Virginia talk about the situation in Germany. I think she'll probably highlight it a little bit more, where there is, in a sense, no firewall. So there is the systematic information exchange between social welfare bodies and the immigration authorities. And obviously, we know from Virginia's long-term experience with Maisha what that means in terms of the consequences for women. And in a sense, it also means that without having a firewall, that undocumented migrants, even though they might have limited rights under the Asylum Seekers Benefit Act, in a sense, it's very hard to actually exercise them in practice because of this, this requirement under the law for the data exchange. So we also, our members in other countries besides Germany are also pressing for firewalls, so that health policies should be defined based on health priorities and not based on immigration control priorities. But the reality is that undocumented migrants don't really migrate because of considerations about accessing healthcare services. They migrate for many different reasons, for family tie reasons, for opportunities, economic opportunities, etc. There's also increasing research that shows that undocumented people, even when they might have a right to healthcare, they massively underutilize the services that are available to them. There was a study by KCE, the Belgian Healthcare Knowledge Center, which estimates that only 10 to 20% of undocumented people in Belgium had contact with medical services in 2013, despite national legislation in Belgium that allows undocumented migrants to have a rather comprehensive set of services. And this study also compared the undocumented group with the Belgian population, and they indicated that 90% of the Belgian population insured with health insurance actually does access to healthcare service. So even when undocumented have the right, they're still not really benefiting from it. So we see while other EU member states, Germany in a sense is a little bit of an outlier. We really see this more as an exception rather than the rule. So while these other EU member states may not require this information exchange with immigration authorities, they also don't formalize firewall recommendations. So they might have the legal entitlement in their laws to the healthcare, but there are rarely any policies that detail what authorities should do to make sure that they can get that healthcare, meaning that they should not be transferring this data. Another example, PICUM did a report on sexual and reproductive health care for undocumented women in 2016. And we gave an example in that report of a young woman who was pregnant while she was working as a cleaner in Denmark. But because she was undocumented, and this kind of relates a little bit to what Virginia was also talking about, she avoided seeking a doctor during her pregnancy. So when she was already seeking a doctor and at an advanced stage, she experienced unbearable pain, and she did go to the hospital where her baby died. The hospital staff reported her to the police, and she was actually issued a deportation order. So these kind of situations are extremely tragic, and yet not entirely unfounded in the European context. And just a final point on the firewall, we also understand many of our members say that sometimes the communication with immigration authorities might happen when the individuals are not paying the medical bills that are issued to them. And I think this speaks very much to what Katrine was talking about, this cost issue. So basically, sometimes undocumented women could be reported to the authorities, not necessarily because they're undocumented, but because they're poor. So I think just as a final point on the firewalls, they're not enough to ensure that the services are affordable, that they're available, that they're good quality, but they would help by addressing the role of criminalization of irregular status and of preventing people who are already in situations of precarity and social exclusion from accessing the health system. I think I'll leave it at that for the moment. Thank you.
Thank you, Michelle. That was very, very elaborate and comprehensive, and thank you for sharing the very, very important examples that link what Joseph was talking about and what Virginia is talking about. I'd just like to remind participants, because we've gotten a couple joining since we started, that we'll actually, after the next round of questions with Claudia, so in about 5 minutes time, we'll be taking questions from participants. Please post your questions or comments on the chat. We'll be using that to then direct the questions to relevant panelists. So if you want to ask a question to Michelle or Katrine or yourself or Virginia or Claudia, just put a name. If not, just ask again the question, and we'll direct the question to the panelists to answer that. So please do that. As then I turn to Claudia to ask her the next question. Claudia, having heard from our previous panelists, about the serious barriers undocumented migrant women face, And in the context of the current COVID-19 pandemic and the widening health inequalities that are impacting undocumented migrant women in Europe, what does the Commissioner for Human Rights see as critical state response? Welcome.
Thank you very much, Enid, and also thank you to the organizer for having invited me to this very important webinar. The commissioner herself, Dunja Mijatović, who comes from Bosnia and Herzegovina, like her predecessors, has given a lot of attention to human rights of migrants, including undocumented migrants and women, of course, but also on human rights of women in general, and particularly sexual and reproductive health and rights. So I think it's very kind of timely that we have this discussion, because it gathers the two elements. So as to your question, I think the main motto that we could mention here is clearly leave no one behind. I mean, the sustainable development goals motto that we know all now for the 2030 agenda, leave no one behind. And I would like to develop on three aspects of your question. That is one on right to health and COVID-19, on the fact that we're speaking of undocumented migrants, and also that we are speaking of maternal health care for women. So if first I mention COVID-19 and health, I would like to inform you that the Commissioner issued an issue paper that is entitled Protecting the Right to Health Through Inclusive, I think it's important here, the word inclusive, and resilient healthcare for all, also important when we say for all. And in this issue paper, I think if we zoom out a little bit, we see that the main general principles that are applicable to the right to health are relevant for undocumented migrant women. Because first of all, what the Commissioner finds critical as a response is to ensure a non-discriminatory access to health services. I mean, this is one of their main elements, non-discrimination in access to health services. And also she calls for a universal health coverage. And this means that it would include, of course, maternal health care, and it would include undocumented migrant women. That should be therefore a well-founded, good quality health systems in all member states of the Council of Europe that are accessible to all without exposing people to financial hardship. And we just mentioned the problem of costs in several of the interventions before as a barrier. And I think this is very important that we have this universal health coverage that will benefit all people. And then also I mentioned, as in COVID-19, maybe the question will arise, it's not directly linked with the maternal health care, but the Commissioner also insists on giving access to all medicines, to all medical products and vaccines also for all in this context. And authorities should figure out the logistics to ensure this quick and fair distribution of medicines and vaccines, both among the whole population and globally. So this is also a message from the Commissioner related to this topic. Now, if I turn to the second aspect, that is that we are speaking of undocumented migrant women, I really would like to stress that this issue of firewalls that was very clearly explained by Michel, and thank you for that, is essential for the Commissioner. So the firewall should be established. And we would also use this ECRI General Policy Recommendation number 16 that you mentioned, Michel, as a kind of basis of what a firewall should look like. It's really important that we prevent authorities, but also private sectors, from denying access to healthcare to undocumented migrants, and in particular, of course, migrant women in the context of maternal healthcare, childbirth. And this is one of the aspects, so separate immigration control and the provision of healthcare services. That's one thing. But also I would like to stress that the commissioners, be it the current commissioner or before also, have always called in a long-standing way for alternatives to detention when it comes to irregular migrants. I think it's also important to stress that here. And when we think of alternative to detention, We think in particular for those vulnerable migrants in vulnerable situation. And here again, I think migrant women who are pregnant would clearly enter this field. Also, and we already mentioned the problem of criminalization. I think the Commissioner for Human Rights has a long-standing call for decriminalizing migration, decriminalizing migrants. I mean, this shouldn't be decriminalized. And also the assistance. And I think when we speak of healthcare, it is very important that those who assist the migrants, and I include there the NGOs working for migrants' rights, including right to healthcare, that these are not criminalized when they exercise a very important service that they give to migrant women. So that's a very important message, I think, from the Commissioner. And the last one, when it comes to undocumented migrants, I think it's also important to say that a critical response to the general problem is that the Commissioner would always recommend regularization of the migrants' situation. I mean, states should find ways to make sure that the people are not in an irregular situation. That will be a regularization process. I can give you an example in a report that was published, I think in 2016 on Switzerland, where the Commissioner at the time, Nils Muizhnieks, recommended to the Swiss authorities to regularize the situation of migrants. And this, of course, would help in access to services, including health care services. And that also includes opening legal and safe routes for migration. I think this is also a very important message from the Commissioner that would kind of facilitate the process. And to conclude my reply, I just wanted also to, of course, go to the point that is access to maternal health care. And in a statement last year devoted to access to sexual and reproductive health and rights in time of COVID-19, the Commissioner noted the increased barriers, I mean, the increased complications when it comes to access to health care, and in particular maternal health care. And there she stressed that to uphold women's rights, in fact, access to quality maternal health care must be maintained even in time of pandemic, and states should give a particular attention to women in vulnerable situations, and that would, of course, include undocumented migrant women. And thank you very much. I'll stop there.
Thank you very much, Claudia. I'll just give a couple of administrative directions. We've been getting requests for the resources, especially there was a question about the WHO report. Joseph, somebody wanted you to talk a little about the report you mentioned, the full title, and maybe, I know we don't have it, you've sent us a couple of resources, but it's not there. Maybe just the title and how somebody can access it, and then we can move on to the next round. Joseph, please.
Yes, we have actually just shared them in the chat. So all the WHO resources are available now in the chat, so they can be accessed. It is the evidence summary, which is the evidence synthesis report on maternal and newborn health, then the technical guidance, which provides policy recommendations, the health status report, which has a summary of some of the findings of the evidence which I presented, and also because we'll be discussing data collection, I'll provide a link to the technical guidance on data collection for health data, migration health data, as part of routine data collection for using health information systems.
Thank you, Joseph. And just to direct the participants to the chat, we've got the links to all the reports there, and also the links to the website for the organization that we are really honored to have today, joining us today. So if you want to get more information, please, somebody's asking, could someone share it? Okay, yeah, we'll post again, we'll repost again. Maybe it's getting lost because the chat is getting quite long. So my team will just continue posting the links to the report. So we don't have, so we'll go to the next round of questions for the panelists. And I'm going to start with Joseph this time. Joseph, could you tell us about some of the WHO's key evidence-based recommendations to European governments for eliminating barriers and inequities and improving maternal health outcomes for undocumented migrant women? Thank you.
Yes, thank you. As I mentioned, we have shared technical guidance on maternal and newborn health, which provides policy recommendations that we have put out about 1.5 to 2 years ago. And the aim was to really improve the knowledge and understanding among policymakers on the magnitude and nature of the issues faced by refugee and migrant women, and to also synthesize the available evidence and then prepare policy recommendations and considerations that could be implemented at country level. Now, there is a lot of recommendations in the publication, plus good practice examples, and it's very much a how-to guide, so practical sort of steps that could be taken to address these issues. But I think I can group them into about 4 or 5 areas. And perhaps taking it from where the previous speaker has sort of already alluded to is the access to maternal and newborn care. And I think, you know, it is key that antenatal care should be easily accessible for migrants, regardless of their status. We make this very clear and advocating very much for access and eradication of barriers, be it administrative, linguistic, legal, financial, and so on. Barriers to access, such as costs of attending healthcare, but this is not just out-of-pocket payments for medication or for consultation, but also things like transportation have to be reduced by providing, when and where possible, maternal and neonatal health services at community clinics rather than in hospitals, and so on. So access is a big issue. Of course, the kind of overarching goal of WHO and main priority is universal health coverage. It's part of also the Sustainable Development Goals. But we cannot achieve universal health coverage without inclusion of refugees and migrants. In the WHO European region, the countries that we covered, the population size is about 900 million, and 90 million out of those are either refugees or migrants. So 1 in 10. And you know, we have to get it right for the 10% of the population if we want to really be serious about universal health coverage. So I think that's my first message. Then there is a set of recommendations around effective communication with healthcare in particular. And then we provide some tips around interpretation, which should be a priority to reduce communication barriers. And there should be investment in skills in local languages for refugees and migrants in the health workforce. We also recommend the use of cultural mediators who can relieve some of the communication barriers. And of course, we advise on the correct protocols to use, especially around confidentiality and non-involvement of third parties and so on. Professional interpreters and cultural mediators should always be used rather than family members. So preference for third-party involvement, of course. We also talk about, and this was before COVID and sort of, you know, this huge use now of telephony and ICT technologies, but we sort of, you know, made some tips and provided information around some of the softwares and telephony equipment that could be used at cost-effective, as a cost-effective alternative to face-to-face interpretations. And of course, support groups specifically tailored, providing information with regard to this targeted group, providing information in native languages and information related to this topic around warning signs of pregnancy, around navigating the healthcare system and antenatal care, and also getting social support during antenatal and postnatal care. So that's around communication. There is another set of recommendations around supporting migrant mothers to actively engage and manage their own health and their own health status. And again, there is a bit around communication, but it's more about information sharing, really. It's about provision of plain language information, socio-culturally appropriate content, communication in a meaningful and reliable way, health information that is easily understandable, production and promotion of health literacy, with taking into consideration different sectors, from health professionals to also health communicators, educators, literacy practitioners, and so on, and peer support networks that can help migrants to develop social networks, including other mothers of similar background who can provide information and share experiences of having already attended services, having self-managed their care, having had having settled in a community, and so on. Now, this is very important. I think the author of this guidance for us was Birgitta Essen from the Uppsala University. We have worked with her very intensively on this, and she was mentioning one example of, for example, the experience she had with, I think it was a Somali community in Sweden, where the migrant community didn't want to have C-section, and she was very surprised because, as you can imagine, in Europe it is actually quite desired now to have C-section, and of course there was a need for understanding why this was happening. If you have C-section in some of these countries of origin, it is very dangerous, and the women were not wanting to go through these procedures. They were very scared. So it was very important to use some of these methods in terms of communication and in terms of also providing this, as I mentioned, socioculturally appropriate content and explanation that actually C-section in Sweden was safe and it was only administered when it was needed, and that it was a very different scenario to the country of origin where these women were coming from. So intercultural communication, very important in terms of improving the outcomes. And finally, I think we also look at quite a lot around the socioeconomic factors. As I said already in the first intervention, we know that there are some factors that can have positive impact, and we were trying to look at some of the factors associated with poor maternal and newborn health and how to address them. So, connecting health professionals and health services and making them interact with other service provisions, such as and other social determinants of health, such as addressing homelessness or housing issues, poverty, and family issues. So I think this is it in a nutshell. Some food for thought. Of course, it's been very important for us also to not just put out these recommendations, but the sort of second part of the job is really to raise awareness of the issues. And we have been advocating and trying to bring this to the forefront, organizing similar to what you have been doing, webinars and events, training and capacity building. We have our summer school on refugee and migrant health, where we have included this topic in the sort of workshops and trainings that we do. And also when we do country, for example, policy dialogues and discussions around national migration health policies, it's something that we try to bring to the forefront. So now it seems like we have quite a bit of the evidence, and this is also sort of becoming now enriched with reports like the one that is being presented today by Katrine, which really is zooming into some of the intricacies of this topic and is really helping us to sort of understand the details. But now also from a WHO perspective, we also have these recommendations. Again, those need to be refreshed and looked at as we progress through time. And for example, now we have heard in the first intervention from Virginia that COVID is significantly impacting the provision of these services. So we need to look at if these are still relevant and if they need to be sort of upgraded or changed. But then, we have to carry on with this sort of awareness raising and dissemination and continue to sort of bring these issues to the table, which we're trying to do through our work with our countries.
Thank you, Joseph, for the very, very practical recommendations that you shared with us. And I think that just naturally leads me to the question I wanted to ask Virginia, and you've alluded to it, Joseph. Virginia, running this organization that works with the undocumented migrant women on a daily basis. We've heard about the recommendations, we've heard about the good work being done by the Commissioner for Human Rights, we've heard about the work that Michelle's organization is doing. I want to ask you specifically about Germany. What do you think needs to be done? If you have to give recommendations to the panelists who are here today, because these are powerful organizations and powerful institutions that are already trying to work towards similar objectives. What needs to be done to ensure that we can enhance access to maternal health care in Germany for undocumented migrant women specifically? And if you have recommendations for the German government itself, and then maybe for EU institutions that you can share with us based on your experience.
I think for Germany, the most important one is the Section 87, the Resident Act, which obliges the public authorities to report the undocumented. If it would be separated, as Michelle and other colleagues said, it would be very helpful, because as long as you know, if you go for services, you would be reported. Then that is already a big barrier for many undocumented migrants. And I think here we need to do something, because it's not only the Section 87, which we are in fact the right to have your own baby. In fact, this is a point we forgot to talk about, because if you are undocumented, you go to deliver, there is already social workers in hospitals who already also inform there is here undocumented migrant woman. She has no address to go to. According to the German law on the child's protection, a baby or a child is not supposed to be homeless. So most of the women, if you are undocumented, you lose already your baby at the hospital. So this is a very big issue, because in fact, we have many women who come out of the hospital where they went to deliver, going home or somewhere without a baby, and you only will get again the baby if you can prove you have a safe place to live with the baby. So how are you going to prove you have a safe place to live with your baby if in fact you are not having any funding, any home? So you will never get your baby back. The other issue is that unconditional maternal health for undocumented migrant women, as for all other women, and also protection regardless to your permit of staying in the country without discrimination. And I think here we need, in fact, as Joseph said, lobbying, awareness raising, also information. Where are there information? And because of the language barrier, many do not even know where is the basic health services. Where can I access it without being reported? So there is a lot of fear, and that leads to bad health care, also accessing to health. And I think here we need to look into how can we as NGO collaborate together to give services which is not based on the authorities, so that the undocumented migrants can access it without fear of being deported.
Thank you. Virginia, I don't know, you were freezing a bit, so I don't know that I don't want to cut you off.
I think the other point I would like to raise, yeah.
Hello?
You didn't hear me?
No, you froze a bit, but yeah, I can hear you.
Now you can hear.
Yes.
I was talking about the access to health and also access to your own baby, because many women lose their babies at the hospital when they go to deliver, because they have no address, they have no home. Child protection law, you cannot, a baby or a child is not supposed to be homeless. So the child is taken away from you. So this approach that we integrate the mother and child, but mother and child are separated. And this also becomes a barrier that many women fear to go to the hospitals because of they could lose their baby. And this is a very, very big issue we have to look into.
Thank you. So thank you, Virginia, for those very good recommendations and very practical things that you're saying need to be done for the women to just feel safe enough to even access the services, even if they were there. But also the fact that these services should be given equitably as they are available to other women as well. I'm going now to move on to Katrine to ask, are there governments in the EU who've already acted to address these barriers that we've been talking about and to improve their laws and policies, in particular with regard to ensuring free and affordable access to care for migrant women? And then maybe you can share some of those good practices that we are saying that can be like a model for other states to follow. So welcome, Katrine.
Thank you, Enid. And so there are 11 EU member states where the law does provide for free or subsidized maternal health care for undocumented migrant women. This is the approach that's taken by Belgium, Estonia, France, Germany, Greece, Italy, the Netherlands, Portugal, Romania, Spain, and Sweden. And I think it's really interesting to note the important differences there are between these 11 countries in terms of their GDP, their health systems and structures and financing models. And this list, as you will all know, includes some of the wealthiest EU countries, but also some of the poorest. And they have very different health systems. And so I think what this shows is that income level is really not decisive for the ability of countries to provide free access to maternal health care for undocumented migrant women throughout pregnancy, and that really it is a question of political will. And in fact, research from the Fundamental Rights Agency shows very clearly that providing for affordable access to preventative and essential antenatal care, which offsets pregnancy-related risks and complications, also reduces women's recourse to expensive emergency care. And so these policies are really cost-effective, in fact. So while these 11 member states have taken important steps towards ensuring universal and equitable access to maternal health care without discrimination based on nationality or immigration status, as I mentioned earlier, and I think as has been highlighted very clearly by both Virginia and Michelle, there are still important barriers in these countries that often impede access to care in practice. But from this group of countries, I think we can highlight maybe Italy, Sweden, and Spain as examples of good practice, because in these countries, their laws provide for free access to maternal health care for undocumented migrant women throughout pregnancy, meaning that they can access both free antenatal care and free skilled care during childbirth. Italy is also, I think, a good example of a country that has a law that includes firewall protection, where the law clearly states that healthcare providers may not report undocumented migrant women to immigration authorities when they are seeking healthcare. Thank you.
Thank you, Katrine. And your mention of firewall just leads me to the next question I wanted to ask Michelle. Michelle, can you share examples of good practices regarding establishing effective firewalls? And what are some of the recommendations that you can suggest in this area for guaranteeing access to affordable maternal health care? Welcome, Michelle.
Thanks, Enid. I think it's interesting to look at what's been developing in the past year during the COVID pandemic to kind of answer that. So we've seen not only with the first phases of lockdown and testing, but also now in the more recent developments concerning the vaccine, that some of the governments in Europe have actually developed measures to reach undocumented people more generally concerning access to healthcare. Portugal, I think, is one that's consistently being alluded to, not only because of the regularization that they held last year. This was a point that was also brought up by Claudia, the importance of regularization, but also their policy coupled with the regularization to ensure that undocumented people could get safe access to healthcare during the pandemic, especially. Ireland has been very explicit about undocumented people being included in the COVID vaccine distribution. The Irish Minister of Health himself has stated clearly that there would be no immigration consequences for people coming forward, and he encouraged undocumented people to come forward to get vaccinated. Also during the lockdowns in 2020, Ireland announced that undocumented people could access the COVID-19 care without data sharing with immigration authorities, and also that they could be included in Ireland's pandemic protection program for workers who lost their jobs. Another example is in Belgium. In Belgium, we have the 3 regions within the federal state. So the Brussels capital region has been very proactive to develop approaches to reach people who in general face significant barriers to the mainstream health system. So these would be migrants in general, as well as homeless people. And here, the health professionals and the authorities see that there's a lack of trust, which is the major obstacle to the vaccine for COVID for people who are homelessness, is also for people who are undocumented. So what's interesting is they've gotten a lot of publicity this week, actually, because they were announcing that mobile vaccination teams will start vaccinating people who are homeless and who are undocumented as of May. And they'll do this by allowing undocumented people to be registered using an adjacent national number. They're calling it the numéro bis, which would be available to anyone who doesn't have a Belgian national ID card. And they'll also do this by setting up specialized kind of places where a number of NGOs and health institutions of the Brussels capital region will work together and ensure that in those places especially, that there would be a firewall. But we also have the agreement from the federal government that they will not send police, for example, to those places or to other places where undocumented would be getting the vaccine. So in terms of a recommendation, and in light of what we've heard from the Center for Reproductive Rights report, we would recommend that policymakers, both at the national and the subnational levels, subnational in countries where healthcare is actually regionally governed, basically, we recommend to reform the legislation and the policies that deny or limit access to sexual and reproductive health services because of residence status. So we recommend reforming them so that these policies are not based on residence status, but that they're ensuring that services are provided based on the needs, the healthcare needs. So this would mean opening up avenues to access comprehensive services for undocumented people. So it's not only as we've seen in our report from 2017 on sexual and reproductive health rights of undocumented women, it's not only ensuring access, for example, to maternal health care, it's also to the broader primary healthcare system, because sometimes countries are also disconnecting them. And then our second recommendation would also be to create firewalls to decouple healthcare services from immigration control, and to not only create them, but also explicitly refer to them and communicate them in a well intentioned way. Here it's also important that we refer to people who have experienced violence, including gender-based violence, including FGM. And we see that in practice, a lot of service providers are the first point of contact for survivors of gender-based violence. So this reinforces the need for firewalls not only to facilitate access to the healthcare sector, but also to support access to justice for people who have experienced gender-based violence and to support their recovery. And we think that such services should be available to all survivors, regardless of residence status, sexual orientation, or identity. This would be consistent with the Istanbul Convention of the Council of Europe and also with the EU Victims of Crime Directive. This would include non-discriminatory access for sex workers, many of whom are migrants who face a double burden of criminalization and stigmatization. And we also think that the European Union itself can play a key role in promoting evidence-based policy dialogue and exchange of good practices. The EU can ensure coherence of sexual and reproductive health objectives in all EU policies relevant to undocumented migrants. So while the EU itself has very limited competence in the area of health, health is mainly governed at the national level within the EU. It does have strong authority under the GDPR, the General Data Protection Regulation, to enforce privacy and data protection rights. This is a regulation that's been in place now for a couple of years in the EU. So the EU can play an important role to hold EU member states accountable under this regulation, under data protection laws, for the processing of personal data in ways that might be incompatible with fundamental rights, including the right to health. Thank you.
Thank you, Michelle, for that very elaborate response. I'm going to turn to Claudia to ask one other question, but in the meantime, I've got a couple of questions, for the panelists. So immediately after Claudia, I'll be coming to ask questions that are in the Q&A box. And Claudia, governments often claim that human rights law does not require them to guarantee access to maternal health care for undocumented migrant women. However, this is not true, is it? Could you tell us a little more about the human rights standards and what those require member states to do to guarantee undocumented migrant women's access to maternal health care throughout pregnancy? Thank you.
Thank you, Enid. Yes, again, I would like to reply to your question in two aspects. One will be about what are the human rights standards that are applicable in this context and what it means for the state obligations, what they require from the state when it comes to access to maternal health care for undocumented migrant women. So here the key motto could be without papers, but not without rights. I mean, it's not because you don't have papers that you don't have the rights, and in particular the right to health. So I think this is very important. And what we see is more not really a lack of awareness, if you want, of the existing standards. Human rights standards are there for sure, and I will mention them. But what we lack is the awareness of the existence of the standards and the consequences they have as an obligation for the state. Health is not a commodity. It is a right. And if we want to go into the most universal document establishing the right to health, we go to the Article 12 of the International Covenant on Economic, Social and Cultural Rights that establishes the right to the highest attainable standard of physical and mental health. So this is applicable to all member states of the Council of Europe and of the European Union. And this means that there are minimum core obligations for state that is to ensure satisfaction of the minimum essential levels of social and economic rights, including this right to health, that are not derogative. So this is clearly stated in the Article 12 of the International Covenant. And this implies that states have to refrain from denying or limiting equal access for all persons, including undocumented migrants, to all health services existing, be they preventive, curative, and etc. I already mentioned the importance of the non-discriminatory access to health facilities. That is very important, particularly for undocumented migrants. This Article 12 implies availability, accessibility, acceptability, quality, affordable healthcare. It's not just something like in the air. It is really concrete standards. We can also quote the CEDAW, the Convention on the Elimination of Discriminations Against Women. Article 12 is also about access to health for women. And I would like to mention also specifically the European Social Charter, the revised European Social Charter. That is a Council of Europe document that in its Article 11 mentions the right to protection to health, and in Article 13, the right to social and medical assistance. And it is quite important to stress that the European Committee of Social Rights, that is the body that implements, that checks the implementation of this European Social Charter by member states, has clearly stated that foreign nationals, whether residing lawfully or not in the country, are entitled to urgent medical assistance and such basic social assistance as is necessary to cope with an immediate state of need. That would include accommodation, food, emergency care, and clothing. And we just spoke about homelessness. And I think it's very important also to stress that food, shelter, and water are elements of very important matter when it comes to ensuring the right to health as a kind of a precondition or a kind of complementary to the right to health. So this is also clearly stated in the European Social Charter. And then I'll say also, mention also the European Convention on Human Rights. It's Article 2 that prohibits, attempt to the right to life, and Article 3 that protects persons from ill treatment, violence, and torture. Now that I've heard this situation from you, Virginia, raising the problem of women being separated from their babies at birth because they are homeless and they wouldn't be able to kind of care of their children. And there's a constant case law of the European Court of Human Rights based on Article 8 of the Convention that is on the private and family life and the principle of non-discrimination, that it is a discrimination to separate a child from the parents on the grounds of socioeconomic aspects. So I think I know more this case law about some Roma women who were been taken their child away on the ground of being homeless or not, or being poor, basically. But I think this would also apply in this situation, I would imagine. So those are the standards, if you want. As you see, they are manifold, and they're all pointing at the same direction. That direction being that women's rights are human rights, and women's sexual and reproductive health and rights are human rights, and this includes the right to health. So what are the obligations for the states? The Commissioner for Human Rights, in an issue paper on access to sexual and reproductive health and rights for women in Europe, mentioned things that were already made as recommendations before, also by Michelle. She says that we have to remove the barriers, that impede access to affordable, good quality maternal health care services. So all barriers should be removed, be it to services, goods, and facilities. That would include prenatal, postnatal care during childbirth, and obstetric emergencies. All barriers, meaning financial, meaning practical, meaning social, cultural, and linguistic barriers. And I think Joseph also mentioned some of these aspects of giving examples of good practices in this respect. And then also reform the laws and policies that apparently still exclude undocumented migrant women from receiving such assistance. So if the law is there, then you reform it, because it is one of the barriers actually to access. I would also stress that one should not neglect in this context the mental health aspect and the emotional well-being of the women, particularly when they are in such a vulnerable situation. I think it's important that this is part and parcel of the measures that are taken by the states that are obligatory for them to take in the context of pregnancy and childbirth. I already mentioned firewalls, but I would also say that it is important to fight gender and racist stereotypes in this context, because I think undocumented migrant women are particularly vulnerable to when they meet social workers or health workers who have this gender and racist stereotypes. So through awareness raising, through training, and in most extreme cases when there is hate speech or violence, of course also accountability for the perpetrators. I think these are also elements that are obligations for the state to take. So if we combine all these mottos, leave no one behind, without paper but not without rights, women's rights are human rights and sexual reproductive health and rights are human rights, then what is the conclusion? It is that states have the obligation to guarantee access to maternal health care for undocumented migrant women. There is no question about that. Thank you.
Thank you very much, Claudia, and to all the panelists for such a rich conversation. We've got about a couple of questions on the chat, and I know we've got about 10 minutes to the end of the webinar. So I'm going to ask. There are two questions directed to Virginia, and then there are two questions that are kind of seeking each of the panelists' views on a couple of issues. So I'll ask Virginia first the two questions, and then I'll ask the question to the panelists and just give each of you a minute to just give their views on that specific issue, and then we'll have a couple of minutes to wrap up what has been a really, really rich conversation. Virginia, there's a question directed to you. And somebody is asking, are there, we talked about the question of women giving birth and their children being taken away. And I know Claudia has also alluded to that. And someone is asking, are there, do you have materials on that you can share, or, information that can be shared on that issue? And then just also a quick question around, are there recommendations on materials about birth control that are out of racial reasons for women in Germany, and that also in terms of intersectional perspective, so accessing birth control for similar women. So maybe 2 minutes for that, Virginia, then I'll ask the questions to other panelists. Virginia, you're on mute.
Sorry. Because of having no lobby, there is very little documentation on cases that are happening. And I think it's high time we try probably to document the voices of those women who are experiencing what they go through, and maybe they can tell their story, because it's only they who are able to tell better than we could do. And maybe something Maisha will start doing by asking the women whether they want to tell their story. The other one is the birth control. We do not, I don't know that there is any kind of lobbying in this direction.
Thank you, Virginia. I've got a question on the chat as well that is asking, let me just, yeah. In some countries, civil society organizations and others who are trying to help undocumented migrants face problems or could be potentially be criminalized for their work. And the question is, could panelists share their views on these issues? For example, maybe Virginia, if you have any, experience of something like that, and from the rest of the panelists, what are your views on these? Have you come across these? Are there protection for such similar organizations that may face that kind of intimidation or harassment or criminalization? So maybe just each of you could just
maybe I think they could be, because I think the protection Maisha has is because it's a joint cooperation project with the city municipality, where in fact is an agreement between the political parties that Frankfurt needed to offer humanitarian counseling, health counseling center. So it is an agreed service. So in other cities, in fact, there have been a lot of lobbying, and we have those kind of centers in more than 8 cities offering health services. But I think it always has to be a political will of the cities and the countries.
The rest of the panelists on the issue of civil society intimidation or harassment? Yes, Michelle?
Yes, thank you. There is a project called Rhizoma, which was a research project which actually looked at this issue of criminalization of humanitarian assistance in the EU. And it found over a 5-year period, and I think the 5-year period was, I think it ended a couple years ago. So it was a very distinct period, but in that period, there were 171 cases of people who were criminalized for providing assistance to undocumented migrants. And this can be a wide range of criminalization for a wide range of activities. So I would say the majority were people pulling people out of the water, preventing them from drowning. There were cases of people who were providing shelter, hosting someone who were undocumented. Cases of people driving their car in a mountainous region, so to avoid hypothermia, of people who were, trying to move in very cold weather. There were most likely some cases of people providing basic like food or assistance. But I would say that they probably weren't the majority. In any case, it still sends a chilling factor, and it's an undercount, because a lot of these cases, those are formal cases. A lot of our members in countries where there's maybe a little bit more hostility to migrants' rights organization talk about kind of a low-level harassment that doesn't manifest itself in a criminal case, but it's low level and it's continuous. We also have members who have had cases against them over many years. In Cyprus, for example, one of our key members has faced charges for their continuous engagement on migrants' rights issues. So it is a reality throughout Europe. And I think it's interesting to hear what Claudia gave as all of the obligations of states. In a sense, that's where we need to go. But I wanted to make the point with that because we've seen within PICUM's experience that healthcare reform is unfortunately, like we've seen this over the past 20 years, we haven't really seen examples of states reforming it by themselves, unfortunately. I mean, we've only ever seen civil society playing a role. Sweden changed its legislation in 2013, and it took about 15 years for a major coalition of almost 80 organizations, civil society and trade unions, coming together over many years. A visit by the UN Special Rapporteur on Health, a formal report on Sweden and its access to healthcare for undocumented, a Swedish parliamentary inquiry. But all of that was instigated by civil society to begin with. France has had legislation in place for more than 20 years concerning access to healthcare for undocumented migrants. Every year it's threatened by the far right. Every year it's in a sense maintained because civil society, health professionals, and the Ministry of Health actually are working very closely together. So I think the question about criminalization is also knowing from our experience that if you don't enable civil society to do the important work that Virginia and Maisha is doing and that others are doing throughout the continent, we most likely won't necessarily see these reforms. So civil society can't be criminalized. I mean, it is the reality that civil society is a key actor here. Civil society produces evidence. We need more of it. But also civil society should, in a sense, have more access to funding. If they are producing part of the common good, which is access to healthcare, and trying to enable migrants to gain access to the mainstream healthcare system, they should be supported, and also with their legal challenges. I think what Claudia was referring to with Virginia's example of the women who are separated from their children also, in a sense, begs for more legal analysis. And could there be potential cases that could be brought forward, but could they also be supported? I think that's another issue. So I definitely think the criminalization of migration in general is the backdrop to everything that we've been hearing in the past hour and a half.
Thank you very much, Michelle. I don't know whether any of the other panelists wants to weigh in before I get to thank everyone for such a rich conversation. Yes, Claudia.
Yes, thank you very much. Just one sentence to say, as I already said, that the commissioner is against criminalization of civil society, but not only that, it is at the heart of a mandate actually to protect human rights defenders, and that includes those who help migrants. And for instance, in the context of rescue at sea, the commissioner made it very clear in several documents that civil society is a major actor in this context and should not only be not criminalized, but should also be helped by the states. And the states should take their own obligations of rescuing people at sea And while they are not doing this, they should certainly not criminalize civil society. So this is also the fact that if anybody hears about this situation of criminalization, it is also possible to report it to us, to the Office of the Commissioner for Human Rights, and we can deal with this situation as well, because that's really part of our mandate of the Commissioner. Thank you.
Thank you very much, Claudia. I'm aware that we have 1 minute to time. I don't know that yourself or Katrine want to say anything before we conclude.
No, thank you. I think it's been great to be part of it. Everything I think has been said, and I think just great to have all these people here together. And I hope we can somehow also follow up after the webinar and collaborate on these issues, or continue the conversations, continue the engagement. I think it's a good group, and I think it would be great from the WHO perspective to have all these voices and all these colleagues with us working together on this issue going forward.
Thank you, Yosef. Katrine, as I wrap up.
Thank you, Enid. I think I'd just like to echo what Yosef has just said. I think it's been a great conversation, and we're very much looking forward to collaborating and finding ways of addressing these issues in the months and years to come. So thank you.
Thank you. Virginia, I know you answered the question. Do you have any last words as a panelist as I close?
I think that networking, especially when we are dealing with campaigns and lobbying for the undocumented, is very important. The PICUM work, we are a member of PICUM, and I think if we all come together and try to share our difficulties from one EU country to another. And thank you very much, everybody.
So in closing this discussion, I really want to express our deep appreciation to all of you, our panelists, for your time and expertise. And I also want to thank our audience for having been with us for 1.5 hours. It has been a very rich conversation. Just a few key points that our panelists have highlighted, in terms of the barriers in accessing affordable maternal health care for undocumented migrant women in the EU. And of course, what we've heard is that these barriers are not in line with WHO's public health guidelines and recommendations, and definitely do not comply with human rights requirement to eliminate discrimination in access to maternal health care for all women, regardless of their status. We've also, however, heard of some good examples and good practices and clear actions that other member states can also use to improve on their policies. And I think the call by yourself for us to continue this conversation, to really harvest those good examples and work together to ensure that we are replicating or supporting actors to replicate those good examples across the EU. And they're also definitely important avenues for EU funding and support to civil society working in this field. I think Michelle and Claudia have really spoken to the fact that not only should the civil society not be criminalized, they should actually be supported, because they are doing a very, very critical function that is useful for the safeguarding access for undocumented migrant women, and actually for other, other human rights as well. And so I really hope that you've enjoyed the conversation. We really do look forward as a center to continue working together to ensure that all women across the EU can access maternal health care that is affordable and of good quality. If you want more information on the center's work in this area, please don't hesitate to contact us, and we'll also be sending the recording of this conversation. I would want to close by really thanking PICUM for having hosted this webinar with us, and to thank all of you for the very, very, very useful partnership that ensures that we can make a small difference in enhancing access to SRHR broadly, but also to quality maternal health care for undocumented migrant women. So thank you so much, dear panelists. Thank you so much, our participants, and looking forward to the next conversation that we'll have and to continue working together. It's a big, big thank you from the center. Thank you so much.